Today I'm going to review what we've learned about disaster impacts on health and demographic outcomes from 4 very unique studies, each of which was a study that had been in the field and then interrupted by a disaster. So I'll review the qualities of the studies that made them interesting for improving the rigor of our understanding of disaster impacts on health. And then I'll conclude with some of the most interesting findings from the studies. Okay. So disasters are often triggered by a weather-related hazard, such as a hurricane, a tornado, a wildfire, a flood, or a drought. And we know that these weather-related hazards are becoming more common as the climate warms. So here you just see something that we all are very well aware of in this room about the acceleration of global warming over time. And these drive environmental disasters so that we can expect to see more of them in the future. So that's why I'm focusing on disasters and how they serve as analogs for what we might see in the future under climate change. Disasters are extremely challenging to study because they cannot be predicted. So you can never plan a study with all of the research design that you might like because you don't know when and where a disaster will strike. So most disaster research that focuses on individual level outcomes adopts a case study approach. And in this design, basically, you have usually a single wave of data collection that occurs after the disaster and asks retrospectively about what happened during the disaster and what were the conditions of the household and individuals prior to the disaster. And occasionally there'll be a follow-up survey so that people are followed over time, but generally the most common is just a single case study with a single observation in time. An experimental research design is a far more preferred approach for measuring the effect of a shock, like a disaster, on any particular outcome. And such a design has 4 desirable elements, which I illustrate here. The first element is the pre- and post-disaster measures, ideally with multiple observations after the disaster exposure. This baseline population measurement ensures that the characteristics of the population exposed to the disaster are measured without recall bias, and it often includes a wide range of measures, much wider than you might have thought to ask in just simply a case study design. These baseline measures also allow researchers to determine whether the post-disaster the post-disaster sample has been affected by loss of population through mortality, migration, or just simply refusal to participate in research design. So it gives us a sense of any kind of bias in the sample. A second quality of experimental design is that if the baseline population is representative of the entire exposed population, it allows findings to be generalizable to that entire place, and perhaps arguably to other places as well. And then if the sample is sufficiently large, it allows us to look at differences within the population in terms of how much they were affected by the disaster exposure and who was more vulnerable. A third element is that it includes a measure of disaster exposure, ideally with both objective and subjective reports of how people experienced that event, and then perhaps other measures. For example, in a flood, you might have a flood depth for a particular house that you can use as an objective measure of exposure. This allows for the possibility of a dose-response effect in the disaster outcome measures, and as well as a differentiation in the types of experiences during the disaster that might have different types of impacts on people's health and well-being. Finally, and the most elusive element of this type of research design is having a comparison group of observationally similar but unexposed individuals that would allow researchers to assess what kind of changes might have occurred even in the absence of the disaster exposure. So comparing these two types of designs is interesting, right? How much difference does the research design actually make in the conclusions that we draw from research? Most research on disasters comes from the field of psychology and documents the traumatic mental health impacts of disaster exposure. A research review of all of these studies of mental health impacts of disasters looked at about 230 studies and found that the majority of them were case study designs. There were a few that adopted a more experimental design, and what they found is that when an experimental design was adopted, it tended to attenuate the effect of the disaster exposure on the mental health outcome. So in other words, this research design really does have an impact on what we conclude from disaster research. At least in the field of psychology, it does. So by chance, disasters have interrupted at least 4 demographic studies led by population health scientists who each were able to propose and receive funding to repurpose the study to really focus on disaster-affected populations and their impacts on population health and demographic behavior. 2 of these studies are shown up here. The first one is the STAR study, which is the survey of tsunami effects in Indonesia that happened after the 2004 tsunami. And the second is a study in Japan of elderly populations. This was a multi-sited study in which one of the 11 sites was extremely impacted by the tsunami. So in that study, we focus on the impacts of the disaster on the health of the elderly population. 2 other studies that were similarly interrupted by a disaster come from New Orleans. And the first one is called Cativa Nola. It's a study of the Vietnamese American population of New Orleans. And so it's all foreign-born Vietnamese living in New Orleans who had been surveyed just before the hurricane to find out about the health and well-being of that population. The second study is the Resilience and Survivors of Katrina survey that looked at a group of low-income African-American women who had been participating in a study of community college retention and graduation rates. And so while this is not a random sample or a representative sample of the population, it is an especially vulnerable group to who would be of theoretical interest. Each of these each of these studies has most of the elements of an experimental design. What you can see here is that while they don't have representative populations, not all of them have representative populations, each of them has a very good sample of a population of interest. They have pre and post measures, and they have both subjective and objective measures of disaster exposure. Mostly they lack a control group. So what have we learned from each of these studies? This is really the most interesting thing to assess in the paper that I submitted to the conference. The first is that they're coming from, the fact that we have multiple observations that come from before and after the disaster means that we can really assess population well-being over a long period of time. And the STAR study, this is the Indonesian study, illustrates really comprehensively with annual data for 10 years post-disaster, the effect of a high mortality disaster event on both short-term and long-term mortality outcomes. So what we find is that and I shouldn't say we, what they found is that there was selective mortality during the event. In other words, some people were more likely to die. They don't have a lot of information about who those people were, but through very rigorous studies, they've shown that they're more likely to have been people who were less healthy and less able to survive the tsunami impact. In other words, to swim their way or to find some sort of refuge. And so what they found is that in communities that were hardest hit, that had the highest mortality rate during the disaster, mortality over the next 10 years for those communities was much lower. So there was selective mortality. They also find that there was scarring from the disaster, and within this population, the people who were most likely, or rather who had higher rates of mortality in the subsequent 10 years, were older men who had mental health issues, mental health trauma from the disaster exposure, and older women whose husbands had died as a result of the tsunami. Those were the two groups that were more likely to die in the next 10 years. There's also heterogeneity in disaster vulnerability to the poor health outcomes. So we already, as I just showed with the scarring effect from the tsunami, that older adults were more likely to have poorer outcomes over the long run. In the risk study, low-income women with pre-disaster mental health conditions were also more vulnerable to having even worse and longer-lasting trauma after disaster exposure. Finally, I'm almost done, we also see from these studies that displacement and housing type were really important moderators of health and well-being after a disaster, but they don't necessarily tell us a straightforward story. For example, in the Japan study, they found that people who moved to public housing, like low-income sort of trailer-type housing, were more likely to have gained weight. And older people who went to live with their family were more likely to have been socially isolated and develop dementia after the disaster. And so these were different kinds of outcomes that were very much related to their housing type and the fact that they were displaced. So to conclude, what I'd like to illustrate is that there are real benefits from from repurposing these studies, but as I began my talk with, it's really hard to plan these, so it's not clear how many more of these studies will ever happen. Instead, I think what we need to do as a community to really understand the complex and variable ways in which disasters affect population health is to look for sources of administrative data that provide ample health measures over a pre- and post-long period of time for a population representative group so that we can better understand the variable impacts of these types of extreme events on population health and well-being. Thank you.